Thank you, everyone. Today, I'm going to present very briefly and provide updates on what we are doing on with regards to provider reporting. And then we're also going to give just like a very high-level overview of the methodologies that we will use for the provider reports. And then I will also provide details on how and when you can provide feedback for these methodologies as well as provider reporting. So on the first item of my presentation, we have conducted the very first provider reporting webinar on June 6th. So providers have attended this one, and we're able to provide them an overview by giving them a template on the provider report that they will be receiving sometime this July for the data that was collected in year 2022. So we collected for the data call in 2022, we collected 2017 to 2019 data. And then we also expect to have another report to share the provider performance from the 2024 ongoing data call, which aims to collect 2020 to 2022 data. We also provided information about public reporting with regards to comparing provider performance versus benchmark growth. And that would start with 2022 data, which is the start of reporting year that has the first set benchmark growth. So in the webinar, we said that we will compare the confidence interval of the growth rate of the adjusted total medical expense, or the TME, per member per month to the benchmark growth rate. So very briefly, the benchmark growth was set by the board in 2021, and it's a combination of the weighted average of the growth rate of the median wage rate as well as the per capita GDP growth rate here in Washington. As for the adjusted total medical expense PMPM, just a reminder that this is the sum of the age and sex risk adjusted truncated claims PMPM plus the unadjusted non-claims PMPM. And then we talked about in the webinar how we adjusted for age and sex risk. And then we also talked about how we truncated claims to be able to get the adjusted total TME PMPM. And then for the confidence interval, which we'll discuss in very briefly in the next slide, we talked about how we pull the different variances that carriers submitted in order to be able to get a singular variance for each provider. So in the next slides, I'm going to just give an overview of these different methodologies, but in an email that we will send in the tab of our packet in tab 5, we have very detailed methodology on how we did these calculations. We also have an Excel file for these different calculations that you can go through. It provides an example and the detailed steps on how to calculate all these calculations. So on method 1, which is truncating claims spending, this means that we do not include some spending that exceeds a certain threshold, and that is to ensure that a very spending from very few high-cost individuals doesn't affect the cost growth of a provider or a carrier. And this threshold was set such that the total amount of per member spending above threshold is about 5% of overall market spending. This is based on an on-point analysis on the 2019 APCD data. And based on that table, you can see that the truncation threshold for commercial, Medicare, and Medicare markets are those numbers. And if we truncate on a per member basis, and based on this data, less than 1% of members have truncated spending, so it's not a lot. So again, more details and examples are in the technical manual. We have provided an example in the technical manual so providers can can understand how truncation was done in the data call. For the second method, which is to adjust truncated claims based on age and sex, and this was decided by the board in the previous meetings. Well, we have detailed documentation on this one in the tabs, as well as some sample calculation that provides very highly technical provides like a highly technical information on how this one is calculated in our provider reporting. So in summary, the adjustment is based on two weights. One is on age and sex risk factor weight, and the population weight of each age and sex combination. So the first weight is the age and sex risk factor weights, and this is calculated by getting the ratio of the PMPM for each age and sex category or sector, and get the ratio to the overall PMPM of the insurance category. So when we calculate the cost growth, this risk factor weight is fixed at the baseline such that this factor weight does not influence the cost growth of a provider. But what does influence the cost growth is the population weight of each age and sex band. So that if there are more members in age and sex band with higher PMPMs for a certain year, then growth is adjusted downwards. And if there are more members in age and sex bands with lower PMPM, then growth is adjusted upwards. So basically the adjustment is to make sure that the cost growth reflects what would cost be if the risk profile is similar to the general population in that particular insurance category. The third methodology that we use in providing performance reporting is pooling of the variances. And this is because we get different standard deviation from carriers, because carriers are the ones submitting the data for all the providers. And so we need to pull this standard deviation to get a single variance, and then this serves as an input to calculate the confidence interval of the growth rate. And then we feed into like the fourth methodology, which is to calculate the confidence interval of the growth rate of the adjusted TME PMPM. Again, more details are in the Excel file. Okay, we will send the Excel file, but this one is in tab 5, which is not in an Excel file format, but the Excel file format should be more friendly and convenient. So in summary, what we do in this one is that we get the risk-adjusted truncated claims spending PMPM, which we talked about in the previous slide. And then we sum it with the non-claims PMPM to get the adjusted TME PMPM. Then we get the pooled variance as an input to calculate the confidence interval, which is specifically the 95% confidence interval, to get the lower bound and the upper bound, and the point estimate should be in between the confidence interval. Then we get this confidence interval of the cost growth and compare it to the benchmark. And so if the lower bound of the confidence interval is greater than the set benchmark, then we said that the performance or the cost growth of the provider is said to exceed the benchmark cost growth. And again, like, I know this is like very quick and very brief because I only have 10 minutes, but more detailed documentation on this one is in tab 5 of the meeting packet. And we welcome any feedback on the methods as well as its documentation. We'll email this separately so it's more convenient for you to read. But if you have feedback, kindly email it to this email address on or before June 26, 2024. Thank you very much.
Thank you, Cheryl. Next, I would like to welcome any public comments. The 6th tab in the committee book contains information related to public comments. It doesn't look like we have public comments at this time, but if you would like to provide public comment, please raise your hand. Then we will call on you and When you're called upon, you will be invited to join the meeting as a panelist. To enable speaking, please join the meeting as a panelist and unmute yourself. Please state your name and your affiliation, if any, before speaking. Please do not raise your hand more than once. This helps to ensure that everyone has an opportunity to speak. If you are also welcome to provide comments in writing via email at any time. Just checking the list right now to see if we have any public comments. If anybody would like to have a public comment at this time, please make sure you raise your hand so we can call upon you. I don't see any hands raised. I will just give it one more glance over before moving on. Okay, that concludes public comment. It doesn't look like we have any hands. Thank you all for attending today's joint committee meeting. That brings us to the end of our meeting today. The recording and summary of this meeting will be posted shortly on our website. Thank you again to all our presenters and for our committee members for attending. For our healthcare stakeholder committee members, thank you for attending both sessions today. Our next committee meeting will be held on Wednesday, August 21st. For our data issues committee members, please stick around. Since we're a little over time, we're just going to jump straight into the next meeting. Thank you all, and this concludes today's meeting.
Good afternoon, everyone. Thanks for sticking around for this final meeting portion, the Advisory Committee on Data Issues. Just a few reminders before we begin. If you're a member of the Advisory Committee and you have not done so, please join as a panelist and mute your microphone. Remember to raise your hand or turn your microphone on when you're ready to speak, and mute your microphone again when you have stopped speaking. We are likely to have most people who will be attending now, as we've just gone directly into this session. So we will begin this meeting. The recording will be posted on the Advisory Committee's website shortly after the meeting. For everyone's reference, today's agenda can be found under the first tab in the materials for this meeting. Okay, welcome to the Advisory Committee members. It is now 4:09 and I call the June 12th meeting of the Advisory Committee on Data Issues to order. My name is Marty Ross. I'm a Senior Policy and Health Data Analyst here at the HCA. We have some pretty exciting discussion ahead in support of the Cost Board and look forward to working with you. To start things off, I'd like to quickly reintroduce the new chair of the Cost Board's Advisory Committee on Data Issues, Dr. Bianca Frogner. Briefly, she is a health economist and a professor of family medicine at the University of Washington, focusing her work on health equity, healthcare workforce, and improving primary care quality and access. If you'd like to introduce yourself a little bit further, Bianca, feel free.
Well, thank you so much again, everybody, for being here, staying on for this last hour. Yeah, my name is Bianca Frogner, and Marty did a nice job introducing me. Thanks for setting me up. I'm really excited to be the chair of this committee and to support this committee's work, to support the board. And I would just say a little bit more of my background is that I've spent a lot of time looking at different kinds of data sources around the healthcare system, both the US and internationally, spending time with claims data, survey data, with an eye on both workforce as well as health systems and reimbursement issues. So I'm really excited about learning from you all about other data that we might want to look at as a group, and to share any of my experiences where useful. So I think with that, I'll go ahead and keep us moving because I know we're already running a little bit late on time. So we're going to start off with a brief overview of the agenda, then proceed to roll call. Next, we'll approve meeting summary from October of 2023. So that's the last time we all met as a committee in a non-joint session. We will hear public comments concerning the materials covered in that meeting, or in this meeting, sorry. And following that, Liz Arjun and Janine Smith from Health Management Associates will lead us in discussion of two policies that the cost board chose to study: facility fees and business oversight, which touches upon mergers and acquisitions and private equity investment in the healthcare field. We will then wrap up and adjourn today's meeting. I encourage committee members to ask questions and provide feedback to help facilitate our discussion and recommendations to the board. And thank you all again for your time and efforts. So I think we'll go ahead and move on to roll call. I will call members by their first name in the order listed on the agenda, which is in alphabetical order by last name. But I would also like to use this opportunity to allow members to get to know a little more about each other. I know you all talked a little bit earlier about your favorite vacation spot. So when I call on you this time around, please unmute your microphone and let us know that you're here, and let us know what your favorite summer pastime is. And then please mute your microphone again. So we will start with roll call for the Advisory Committee on Data Issues. Committee members, starting off with Krista. Krista Abel.
Yes, I am still here. Krista Abel, I'm with Virginia Mason Franciscan Health. My favorite activity is hiking up in the Puyallup Loop Trail. I live over in Puyallup, and it's a lovely trail. I take my golden retriever up in there, and it's very refreshing, and just love to get up in the trees and the hills and get some exercise.
That sounds lovely. Oh, and days like today are probably a good day to be out there to do that. So thank you for being here. Let's move to Megan Atkinson.
Hi, Megan Atkinson, Healthcare Authority CFO. Again, I'm going to be sticking with my theme of going to the beach, but the kids and I we always just have the most fabulous time when we just go over to ocean shores, and nothing fancy, just play in the waves and walk along and enjoy the sound of the ocean and the calming and the sand. And yeah, it's just a great day.
Ah, that sounds so lovely too. I'd love doing that also. Amanda Avalos.
Hey, good afternoon. Amanda Avalos, Deputy for Enterprise Analytics with the Healthcare Authority. And I love to get outside and garden, particularly fruits and vegetables.
Oh, now's a good time. God, just protect them all from the birds and the other bugs that eat them. That's great. Let's go with Jonathan Bennett.
Yeah, Jonathan Bennett with Washington State Hospital Association. One of my favorite activities in the summertime is boating, whether it's water sports, lounging, what have you, just being on the water.
Oh, that sounds so great. Do you fish too out there?
Definitely throwing a little bit of that as well.
Great, great. How about Bruce Brazier? Is Bruce here? I don't see him. Okay, let's move forward. Committee, please, let me know if anyone shows up. Okay, Jason Brown, are you here? Not seeing Jason. Okay, Chandra Hicks.
Hi, I'm still here, and my favorite activity is seeing the sunflowers in my garden.
Ooh, that sounds lovely. All right, Leah Hull Marshall. You still on?
I think she had to step up.
Okay. Li Chao Li?
Hi, I am Li Xiaoli. I'm the chief actuary with OIC. My favorite summertime hiking is hiking around the South Sound area. There's so many nice trails to hike. I have to let everybody know that I have to head out early because I have another commitment at 4:30. So thank you.
All right. No problem. Thank you for letting us know. David Mancuso. Sorry.
Yes, no worries. David Mancuso. I'm an economist with the DSHS Research and Data Analysis Division. I will also go with gardening, and specifically fruit and vegetables, as opposed to things that are more ornamental.
That sounds great. Anna Morales.
Hi there, I'm Anna Morales with United Healthcare. I'm the National Director for APM reporting. My favorite pastime is actually driving up to Vegas with my sisters and mom. I'm one of 5 girls, and we call it our Sisters Without Misters
Oh, I
weekend.
love the
Yeah,
name.
thanks.
Oh, great. Oh, that's great. All right. How about Hunter Plummer? A Plumer?
Yeah, Hunter Plumer. I'm a consultant with Health Trends, and my favorite pastime is hiking, backpacking. We really are just so fortunate having so many opportunities out here in the Pac Northwest.
Well, that was so fun to hear everybody's summer pastimes. And I'll just add that all of you covered a lot of the things I like, which is just spending time outdoors, hiking, boating, you name it, just spending time in the garden. So wonderful to get to know you all in this way. All right, so let's keep us moving. Let's open slides tab 2 to the meeting summaries, and please join me in reviewing that section where we're going to approve the meeting summary.
I think you missed the
oh.
last column of names of individuals.
Oh, sorry.
Oh,
Oh,
that's
sorry.
okay. Just
Oh, I
wanted to-
see. Sorry. I think I'm sorry. I was looking at the agenda and I had it kind of pulled over to the side. So I'm sorry about that. Mark Pregler.
Mark Pregler with Washington Health Alliance, and like my vacation destinations, I enjoy hiking, backpacking in the North Cascade area.
Okay, great. Russ Schust?
Schust, yeah, thanks. Senior Director of Medical Economics for Optum. And my wife and I last year started camping in Washington State and love it. So last summer, and we're looking forward to this summer, camping all around.
Oh, it's a great place to camp. Lots of great sites.
Mm-hmm.
All right, Mandy Stair? Star? Am I pronouncing it right? All right, I'm not seeing Mandy. How about Julie Sylvester? Okay, and is there anyone that I missed or left out or may have joined? Okay, now I'm not hearing anybody. Okay, so now I think I can move on. Sorry, I jumped ahead early. And let's go to the second tab and approve the meeting summary now. As a note, the recording of the last meetings is posted on our website for reference. And we will use the consensus process for a vote on the approval of the meeting summary from October 3rd of 2023, the last time, again, this committee met in a non-joint session. So I think we'll start with, is there any discussion of the October 3rd meeting summary, or are there any proposed changes? Please feel free to unmute yourself or raise your hands. I don't think I'm seeing anything. Is there a motion to approve the minutes?
Motion to approve.
All right, thank you, Amanda. Is there a second?
Second.
I think I saw Russ maybe be the first one. Thank you. All in favor say aye.
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 Any opposed? Okay, not hearing anything. I think we can move ahead next to public comments. We would like to go ahead and welcome public comments, but I'll turn that over to Marty to kind of lead that process.
Great, yeah. Time for public comments. We did not receive written public comment prior to the meeting, but if you'd like to provide public comment now, please raise your hand using your Zoom controls. When you're called upon, you'll be invited to join the meeting as a panelist. To enable speaking, please join the meeting as the panelist and unmute yourself. Please state your name and affiliation, if any, before speaking. Please do not raise your hand more than once. This helps to ensure that everyone has a chance to speak. You are also welcome to provide comments in writing via email at any time before or after the meeting. Please remember that this is the time for public comments. The remainder of the meeting is designated for the advisory committee members to ask questions and have discussions. I'll now open the floor for public comments. Keep an eye out for raised hands. Just give it a few moments. Okay, seeing no raised hands, I think we can, I'll turn it back over to Chair Frogner. Thank you.
Okay, thank you. All right, so then we'll move along. I'm going to turn it over to Liz Arjun of the Health Management Associates to lead us in a discussion of the current landscape of facility fees in the state of Washington and potential policy options which could increase transparency. This presentation can be found on tab 4 of your packets. So welcome back, Liz.
Actually, Chair Frogner, this is Gary. We
Gary.
did a little switcheroo here,
Oh,
so I'm gonna
okay,
be,
sorry.
I'm gonna be
Great.
doing this, so thank you.
Thank you, Gary.
Thank you. So next slide, please. I'm gonna try to move reasonably quickly since I know we're a little bit short on time. So the focus of this conversation and what the board would like from this committee is help in identifying gaps in the data that is received with respect to facility fees and how those gaps might be filled and what the best way would be to obtain the data. So just for definition, a facility fee is a charge that's imposed on a patient not directly related to the service that was provided, but intended to capture overhead costs associated with the facility that's providing the service. The classic example in the past has always been the ED, where a fee is charged because the ED has to be open 24/7 and incurs costs that are not directly related to providing services. So this additional fee has been charged. But increasingly, those fees have been applied in other settings, and particularly in hospital-owned provider clinics, but also in non-hospital owned provider clinics, such as ambulatory service centers, and surgery centers, and others. So we'll talk about that in a minute. So as a result, the charges are higher, and there's been concern that patients might pay less if they went to a different facility, not knowing that they were being charged a fee from the facility that they wouldn't be charged if they went to a provider that was not associated with a hospital. In 2022, hospitals in Washington collected more than $125 million in revenue from facility fees, with the average fee being $100 per patient encounter. Next slide, please. So under current Washington law and regulation, only hospitals are required to report this data, and only for certain types of facility fees. Fees are not required to be reported by providers not affiliated with a health system or hospital. In addition, what is required to be reported is the number of facilities that charge such fees, the total revenue obtained, the number of patient encounters where facility fees were charged, and the minimum and maximum sort of a range of what the fees are. That's what's being reported now. And there's a concern that not all fees are being reported, and current law provides no enforcement mechanism in the event that an institution is not adequately reporting in compliance with the requirement. Next slide, please. So a number of policies have been put forward to address facilities fees. This is an issue that has come up in many states across the country, and in site-neutral regulation under Medicare that's been proposed in Congress, although not passed. Those requirements include improved notice requirements. And then in a few states, facility fees have been prohibited entirely, or they've been limited by the type of service provided or the location of the service. For example, an on-campus facility versus an off-campus facility. Next slide, please. So this, I've pretty much covered what's being required now and what's not being required now. So we can move to the next slide. Thank you. So the question is, oh wait, I've covered this one too. Let's go to the next slide. So here are the questions for discussion. Should the advanced notice requirements for patients be adjusted? Should greater transparency be provided? Should there be adjustments in who must provide advance notice to include other services such as diagnostic testing, lab testing, or other routine services that are not currently required to be reported, or at facilities that are not required to provide notice, I should say. And then should there actually be adjustments in who can charge a facility fee and in what, for what types of services and what types of locations. So given the policy debate that's happening around these fees, the question then is, should the reporting requirements be adjusted to add additional facilities and services in the hospital health system? And should there be requirement of reporting in non-hospital affiliated facilities? And should greater detail be provided about the amount of fees, frequency of charging higher fees, et cetera? So those are the issues that we would love input from the committee.
Thank you, Gary. So yes, this is the time now for committee members to go ahead and unmute yourself and maybe raise your hand, and we can hear from you about your thoughts on these discussion questions. This is certainly your opportunity to provide your perspective or opinions on this matter. And feel free to also ask any clarifying questions if that's helpful. And again, the hope here is that the Healthcare Cost Transparency Board is looking for some of your guidance also on how to look at facility fees as we better understand the cost benchmarking. Amanda.
A couple of just had clarifying questions for Gary. So it sounds like there's maybe two pieces here that we're looking at. One is around transparency, and do we have enough transparency to really wrap our heads around what's happening with facility fees? And in part, I think I heard that you said that there's not a strong requirement, no penalties, and there may be under-reporting potentially, as well as the scope is not comprehensive in terms of who is even being asked to report. And then it sounds like the other piece around recognition of the burden to patients of these facility fees, you know, whether should be reduction of the fees. I didn't hear anything about a cap. Is there an existing cap on these fees, or is that something other states have done?
I've seen other states. I'd have to go back and check to make sure I'm right about this, but I don't think I've seen states that have imposed a cap. I think the tendency has been more to, some states have said, have listed different types of services for which a facility fee may not be charged. And then Connecticut and Indiana, and I think there's at least one other state just recently went ahead and banned them altogether.
Thank you for those questions, Amanda. Any other comments or questions or responses to these questions here? Or feelings?
This is Krista Abel with Virginia Mason Franciscan Health. I wish I knew more about this particular topic to be more helpful here. I apologize. This is not my expertise. I'm just looking at the first sentence where it says, should there be greater transparency as to the amount of the charge? It's not the charge that it's, you know, the patient is coming in that they're not going to get, it's not the charge that they're going to get exposed to, rather it's the amount that's going to get paid in each the case. So just want to make that distinction. And I think there's confusion about what is the definition of facility fee. I've always thought of that as being defined as you have clinics that are outside of the hospital setting, and the patient will get two bills. They'll get one from the physician and they'll get another one from the hospital. But it sounds like this is more comprehensive than that. So, you know, I can take this back and maybe, you know, provide feedback later, but I can't provide too much input right now.
Thank you, Krista. Gary, are you able to provide a little context of how this, how you're just defining facility fees relative?
Yeah, there is a definition in statute, and I can provide that. Maybe I can send that to the HCA staff and they can distribute that to the committee, right? You know, shortly after the meeting. But there is a definition in statute for what we're talking about when we talk about a facility fee.
And then in
And
terms
it,
of.
and
the
it's what I
ability-
said at the beginning, it's any charge that is not directly related to services provided, but intended to cover overhead. And it can be an on-campus or an off-campus facility that is owned by the hospital.
Maybe if I heard Krista's question to it, initially, it's about also the difference between a charge versus what is actually paid for, required to be paid for by the patient.
So the patient, I mean, Chris is right, that the patient will only be responsible for their copay or cost share of the charge. So the charge may be paid by private insurance, it might be paid by Medicare, and the patient will be responsible for their portion.
Thank you, Gary. And thank you, Krista, for your questions. Jonathan.
Yeah, so I have a couple things. I mean, this is the first time I'm seeing it, so we'll probably be providing more additional feedback as we have a chance to kind of consume this. But a couple of things that kind of come to mind when we're looking at this. You'd mentioned kind of just the 24/7 cost of an emergency, making sure that we're covering some of those overhead costs. I think a big part of this is also to ensure that the patient access is still there, right? So a lot of the facility fees are there to cover specialty services that may not be accessible in all these communities. So it's about patient access, and I don't want to lose that aspect of it as an unintended consequence. So I think that's a big piece. And then I'm not sure I completely agree with you on that the costs are not directly related to the service provided. I mean, if you're looking at it, it's covering the cost of the building, staffing, other aspects of providing that care. So not completely sure we're in alignment with that piece of it. But a big part of it is making sure that we were charged with making sure that the unintended consequences are also factored into the equation, and we're discussing that. And I think the patient access is a big piece of that. So like I said, I want to have an opportunity to kind of digest this more and be able to have the opportunity to circle back and provide additional feedback.
Okay, thank you, Jonathan. And I see that the staff has put up Ingress Substitute House Bill 2582. It's related to billing practices for healthcare services. I don't know if HCA staff wants to provide a little bit more context or summary of this. It's also, I believe, in your packet after the slides. But provide you some sense of what is currently in law here in the
This is
state.
just the original enacting bill of facility fees. So if you also click the RCW link in that last slide that we were looking at, it'll take you to the original RCW as well. So that you have it both context, so you can see it in the statute and you can see the original enacting bill and its intent.
Okay, I'm having a little hard time hearing you. I don't know if it's just me or if others are having the same problem.
I'll talk louder.
Oh, thank you.
So in this slide right here, you can click the link at the bottom and that'll take you to the RCW, which is the statute governing facility fees. In the item that we displayed just a little bit ago, that's the original enacting legislation for the RCW, so that you can sort of see some background, a little bit more context for it outside of the statute.
Okay,
I just put in the chat the definition that's in the statute, and it refers to a separate charge. So Chris, to follow up on Chris's point, in addition to a professional fee for physician services. So that's the definition. So it's in the chat.
Thank you, Gary.
Thank you.
Okay, so I'm seeing that we're kind of coming up on time here for this portion of the discussion. So thank you so much, Gary, for your presentation and for fielding questions, and to the committee for your responses and questions. So while we go ahead and move forward, I would like to welcome and introduce Janine Smith, also from Health Management Associates. I believe she's there. She'll give an overview of consolidation in the field of healthcare, both causes and implications. She will review what data sources are available to monitor mergers and acquisitions, then lead us in a discussion again of what policies could be leveraged to ensure healthcare quality and access and make sure that that's preserved in our state. So Please, Janine, please go ahead.
Okay. To all, I'm going to go over this section, and we just presented some further details about this to the cost board itself just recently. So the last presentation booklet would have even further details, and there's some references at the end. The purpose of this section is to kind of introduce this to you. Because the cost board really would like your assistance to think through some of the data needs that might be necessary for enhancing business oversight. And so further discussion about this will occur also at a subsequent meeting for you guys here in the data group. So business oversight strategies is a big bucket of mergers and acquisitions, private equity investments, and provider ownership and closures that have impacts on the healthcare delivery marketplace. They all contribute to consolidation, and consolidation can increase, sometimes it's good for some of these entities because it increases their leverage in negotiations for contracts with health plans. It can lead, however, then subsequently to increases in prices for visits and raise premiums. It can also, it can have a lot of mixed implications for access to care subsequently because of those increased costs. Next slide. So there's different types of consolidation. There's horizontal, which is between entities that might be delivering all the same types of services. We're seeing this, I'm from the Portland HMA office, and we're seeing this down in the Portland metro area as one of our biggest health systems is now planning to merge with another big health system here in the Portland metro area. So that would be horizontal integration. Vertical is if the hospital, say, or insurers are buying physician practices, urgent care entities, or other types of ambulatory surgical centers or other facilities. So that's more from someone buying down the chain of delivery system. Cross-sector mergers are often not as scrutinized because they can be in different areas. So if someone from either out of state or another part of the state buys something in another region, that's kind of what's considered a cross-sector merger. And then there's the role of private equity. It can be part of one of these mergers, but private equity is often pools funding from investors that might have no affiliation with healthcare to invest in the healthcare sector or other, and certainly this occurs in other industries as well. And then closures. Again, not to use Oregon too much, but I'm sure you have them in Washington state as well. But, closing lines of business, rural, such as the OB unit at one of our hospitals was closed and then had to be, the community was left without those services. Rural hospitals, that all of those, how do we know what's going on there? And then there are some other softer forms of acquisitions where entities might come together in a clinical integrated network in order to participate in certain things, such as what Medicare often offers for some shared savings programs or what are called accountable care organizations. Washington State has a fairly significant degree of consolidation and integration. A lot of that is outlined in the recent reports from the OIC and the Attorney General. I have the references for those later that you might want to take a look at, where they talk about kind of the state of Washington in this area a bit further. Next slide. So the cost board is sort of considering what can they do in this area, what kind of policies should they consider to recommend and to enhance this oversight of these business practices. And one would be to expand the review and approval authority of the Attorney General. It's one they've sort of is on the table, giving authority to other entities to review and approve or just review and report additional outside of the Attorney General's office. And then whether there needs to be a better collection of information or a database that really helps be able to track and follow and see what's happening, and who's buying whom, and you know, what does it mean? Because sometimes it's hard to know what kind of enforcement you might want to do until you really know what's happening. So next 3 slides, I'll go through kind of those in a little bit further in the terms of what the ask is for your committee is, you know, what does Washington State already collect in these areas that would play into these policies, and what is needed to enhance the understanding and oversight and enforcement that is needed to make policy. Next slide. So mergers and acquisitions, there is authority for the state to require notice and review. It's given to the Office of the Attorney General. There are certain criteria over who needs to report to them. It's the hospitals, hospital systems, or provider organizations if it's more than 7 entities or people in that group. With a proposed material change, that means that there would be a change between you know, that wasn't there before. They were not connected, and now they're going to be connected and starting to contract with entities as a merged group. And there is a requirement that if, you know, if they have to do any federal reporting about their merger, then they also would need to report to the Attorney General. So they collect a certain subset of information like who, where, and what exactly are they doing, and when is it going to happen? And then the AG looks at it, really trying to capture, are any of these transactions going to be anti-competitive? Next slide. As far as private equity goes, there isn't really a specific requirement. Private equity could be involved in those mergers and acquisitions, but unless they're part of that statutory requirement, or if they're reporting because it's a health plan is somehow involved in that merger or acquisition or purchase, then it might come in through the OIC's financial filings from health plans. So most of the information we know about private equity is there's some discussion of this also in the OIC report and the Attorney General's report, but it's really the focus of a private equity buying something is to get a return on investment for their investors. You have to kind of go out searching to find out what has happened in Washington State, but there's about 97 healthcare acquisitions in the last decade. The areas most commonly acquired are anesthesia practices or groups of providers, emergency medicine, often the staffing for an emergency room, the providers themselves, and post-acute care, you know, such as nursing homes and transitional assisted living, in addition to other specialties. It varies by state as to, you know, where the focus is, but that's what they see in Washington State. Oregon, we have a pretty high dermatology and some physical therapy, so it varies. And then there are also, you know, the big companies coming in like CVS, Amazon, United Healthcare, coming in and buying practices. As far as, you know, if a provider entity is being bought, or if there is a closure, there is a bit of information that Washington State currently collects. There's the Department of Health is required to, you know, license facilities, so they get information, and certificate of need statutory requirements are in place. And as well as, of course, the department collects hospital financials and utilization. The Office of the Commissioner, Insurance Commissioner, really only gets information if a health plan becomes an owner. So we actually, you know, like if a big health plan wanted to come in and buy a clinic, then it would probably be reported on their next financial reporting, but you wouldn't necessarily get an alert that they've done it ahead of time. Medicaid, in order to be a provider under Apple Health, you have to fill out an initial application. So if a new provider came in, they would get some information. But again, that's a whole nother agency separate from DOH. The Washington Medical Commission, they get some individual physician licensing information as people apply for and renew their licenses. And the Office of the Attorney General, again, if it's part of a material change in the merger acquisition realm, then they would get some information. So there's some gaps in getting a comprehensive database around who owns whom. And there's no requirement necessarily if a private equity firm is buying versus another practice is buying, there's no differentiation necessarily as to how much private equity is happening. And there may not be as much focus from the Attorney General's office to look at cross-market because it's not necessarily anti-competitive. Excuse me. But there isn't really a, what's really going on in this region versus that region and what impact would that have? And then closure and reduction in service lines. It might come in through the number of licensed beds, but it may not. It just depends. And so it may not be reviewed by the AG or DOH necessarily and doesn't always require prior notice or approval. Next slide. Excuse me. This table just sort of summarizes the focus, of what's going on in hospitals and hospital systems, what's going on with private equity, and what's going on with provider groups, and then who's doing what. So it just sort of summarizes what I just went through. Next slide. So really the next steps is for you all to think through some of these issues and come prepared for your next meeting to discuss additional data that maybe should be collected or where, think about the gaps in information and authority to consider what kind of recommendations or thoughts on that could be provided to the cost board. Those two reports I was mentioning, the links are right here, the Office of the Insurance Commissioners and the AG's report. I also provided Massachusetts, which is probably the kind of a national leader in this area. They have a registration of provider organizations database that is quite impressive, and what they and also outlines some of what they do with that. And then I think there are some additional resources on the next couple of slides for you all to look at that were provided during the cost board's presentations. So with that, I will stop. There's information in here about Oregon's annual report as well. We've started to collect information on mergers and acquisitions. They're going to have to look at this big one that's going on in Portland here. It's also part of our cost trends work down here in the state. So I'll stop and see if there are questions as you guys head off with your homework assignment.
Thank you, Janine, for that great presentation and for giving the committee some homework to do, but things to think about and references and resources to prepare them for the next discussion. So as Janine suggested, right now, this is an opportunity to ask any clarifying questions before you set off on the homework to think through a little bit more what kinds of data do we think we want to see or collect. So committee members, any questions or thoughts or reactions?
I do see that Amanda has put a note in the chat of another report that didn't make it to our list.
Okay, great. Perhaps we can share that around with the committee members afterwards.
Yep.
I mean, I can certainly say as someone who's spent a little time thinking about mergers and acquisitions in healthcare that the idea that there isn't a comprehensive database is certainly an issue. I think there's a lot of attention on hospital mergers and acquisitions, but slowly, I think, are we getting a better sense of what's happening in the long-term care market around skilled nursing facilities, let alone the cross kind of purchasing across multiple healthcare entities where different business lines are connecting with each other. So I think there's growing attention to the pharmacy market too, obviously. But each group kind of is thought about somewhat separately. So I appreciate
There is a health, there's been some purchases of a couple of practices, big practices, and big part of a couple of cities here in Oregon recently that they've looked at that had to actually be emergently approved because otherwise the practice was going to have to close entirely. So it isn't always necessarily a terrible thing to be merged, but it is have potential consequences depending on how long, there's authority to continue to monitor them once they've been approved for mergers in the Oregon statutes. Massachusetts also does an impact study on what they anticipate would happen down the road. And I think they also have some authority to monitor that going forward. So those are some of the other aspects that the cost board will have to be thinking about. But again, what kind of data is most valuable for that collection?
I mean, Janine, I actually appreciate that framing that you just provided there, because I certainly have seen too that the challenges, the action of a mergers and acquisition versus what happens afterwards and how long to look beyond that and what is it that you're looking for to happen. And
Right.
Maybe that's something for the committee to think about. It's also time frame for how long do we look out for what happens after a merger and acquisition.
And then and again, what kind of information would you need to know that? And I think that's where the data, thinking through the data is very valuable as to, does that mean have the fees suddenly gone up, facility fees gone up because the hospital bought those practices? And then that leads to your ambulatory services going up as a state. So, or is there something else going on?
I appreciate you threading the needle through the prior presentation topics, which is great.
Well, and this is Chris Dable, and I want not to lose sight of the fact that many of these mergers are occurring because these organizations are in financial jeopardy, that they can't survive on their own. And particularly with provider groups, I know with the small provider groups, I hear often that they are struggling with getting any kind of increases in rates over time, that they can't keep up because they're kind of being ignored by the health plans that are not providing them with the increases that they need. So in my experience, many of these mergers are because they can't survive on their own and they have to merge with larger organizations to survive financially.
Thank you, Krista. So I think I'm hearing there is that among the things to pay attention to is not just the group that's doing the acquisition, but who is being acquired and their financial state, perhaps.
Right, and I don't think it always necessarily creates higher costs. I think that's an assumption because in my experience in mergers, we haven't not demanded that the price point increase. We have not done that, and so I think it's an assumption that happens, and I'm not going to say that it doesn't, because I don't know what other groups are doing or historically what has been done, but I just don't think that can be an across the board assumption that it's always a bad thing.
So I think another suggestion there that I'm hearing is also paying attention to any changes in costs, whether it be the costs for the actual organization themselves that was acquired or merged, as well as probably on the patient side too, of what changes that they see perhaps out of pocket, which is I think some of the concerns that were raised in the board meeting about is kind of what is the customer patient experience with a merger and acquisition in terms of how that affects their out of pocket costs.
Yes.
Other thoughts from committee members? We have a few more minutes here before we close up the meeting. I know it's been a long day. And again, I guess we'll be returning back to this at our next meeting. Jonathan.
Yeah, so if we do have questions in the meantime before our next meeting, what's the process of the reaching out and getting some clarity there?
Marty, do you think you can answer that question?
Yeah, if you could respond to the email that you would have received this this invite to this meeting from, yeah, the data advisory email, we'll be able to incorporate your feedback.
Just
Okay,
as a reminder,
perfect.
don't use the reply all button, because that creates an open public meeting. Just respond directly to staff here at HCA.
All right, so did committee members hear that? So don't do a reply all, try to respond directly to Marty or the HCA email address.
Yeah, and then I will say, I'll just echo the last comment made about kind of the current financial stability of hospitals today. A lot of our smaller hospitals, I mean, in general, across the board, are experiencing more financial distress. I'll also say our beds, available beds to census in Washington is very low if you compare us to other states. So in order to preserve access, that's a lot of the reasons why we're seeing more of these mergers and acquisitions. It's not just about dollars and cents, it's about patient access and making sure that the communities that we serve across the state have those ability to get care.
Thank you, Jonathan. I noticed that Russ, you're unmuted. I don't know if you wanted to jump in here and say something.
I was actually going to ask, when is the next meeting if someone knew off the top?
I think next slide has it.
The last slide.
Yep.
21st. Thank you very much.
And Krista, I see that you're unmuted. Did you have additional thoughts or questions?
No, sorry.
No, it's okay. I just want to make sure everyone has their chance. And
Thank you.
Marty also put the email address to also use if you have feedback. Okay. I don't want to necessarily extend this longer than it needs to, but just want to make sure everyone has a chance to express their questions, express any concerns, just want any clarification before we end this meeting. Okay, hearing none, I'll go ahead and bring this meeting to a close. We've come to the end of our meeting, and the recording and meeting materials of this of today's meeting will be posted shortly on the website. And thank you again to all of our presenters, Janine and Gary, for being here today. And as you know, the next meeting is Wednesday, August 21st, where we will follow on from where discussion will follow from our July 30th cost board meeting, building towards a 2024 report to the legislature. So thank you to all of our committee members for attending today, and I look forward to seeing you at the next meeting. It's great working with you all.
Thank you.
Have this day. Thank you.
Bye-bye.
Bye.